My name is Laura, and in my group we have Shannon, Christopher, Peter, and Zoe. The case we will be exploring is Paul, who is diagnosed with medial tibial stress syndrome. Paul is a 37-year-old search and rescue police officer who has been increasing his fitness to keep up with his work standards. He has started increasing weekly runnings to 20 kilometers in minimalist running shoes. Exploring Paul's MTSS, we are going to look at the origin, function, and location of the orthoses that may be used to benefit Paul. However, a study conducted by Winkelmann and others in 2016 don't show one cause for MTSS, but show that there are more than 100 risk factors, and those that contribute the most were BMI, navicular drop, ankle dorsiflexion range of motion in the foot and hips such as ankle plantar flexion and hip external rotation. So what is the origin of the patient's complaint? Paul complains of pain on the palpation of the lower third of medial tibias and has been present for over 2 months. After conducting multiple biomechanical assessment, it is established that Paul has pronated feet because of the mechanics of the foot along the posterior leg muscles. Due to Paul's pronated feet, his pain appears to be associated with increased stress of mainly the tibialis posterior muscle. This muscle is used to hold up the medial longitudinal arch, and due to the consistent stress applied, it causes the arch to become weak and collapse, contributing to MTSS. So what is the function of the tissue that is overloaded? Regarding to Paul, he has pronated feet, and looking at his test results, such as the foot posture index assessment, his results were a +7, meaning he was pronated. However, more specifically, his medial arch height on both feet is a +2, which is considered flat feet. And secondly, his navicular drop and drift is over 20 millimeters, which is a 10 millimeters above the normal range. Hamster, Wright, and others showed that a great navicular drop was most common in groups with MTSS. Both these results are influenced by the tibialis posterior muscles. Tibialis posterior originates on the posterior shaft of the tibia and fibula and inserts to the tuberosity of the navicular bone and spring ligament. The tibialis posterior is an inverter of the ankle, subtalar joint, and midfoot joints. It is also a plantar flexor of the foot at the ankle, which is used to support the medial longitudinal arch. So where do you want to locate the force of the orthosis? If the orthosis force is applied towards the medial axis of the subtalar and midfoot joints, it forms an external supination moment, which is ideal for Paul, who is pronate. Therefore, an orthosis will increase an external supination, causing a decrease in the force required by the tibia posterior muscles, producing eversion to the rear foot and the midfoot.
Orthotic prescription. Orthotic type. For Paul, the most appropriate type of orthosis will be a traditional custom-made orthosis. This is because a traditional type of orthosis has a fat pad which enables more cushioning around the heel. This is important as Paul has been diagnosed with medial tibial stress syndrome, and according to Craig, shock absorption insoles have been one of the few prevention methods that have shown to reduce pain in people with MTSS. Another feature of the traditional orthosis offers is the lateral support. This is important for Paul as he has a pronated foot with an FPI of +7. The lateral support doesn't allow the foot to slip in the shoe, and this will be important for the effect of the orthosis. Arch fill technique. For Paul, an appropriate arch fill technique would be a mid-arch fill. This is because he has shown to have 20 millimeters of navicular bone drop and drift, which isn't in a normal range. A mid-arch fill technique has its high point under the talonavicular joint, which will provide correction for Paul as he is over 10 millimeters out of normal range. According to Hamster, Wright, and others, individuals with a navicular drop are more likely to be at risk of suffering MTSS or are more likely to have the condition. Thus, as Paul has been diagnosed with MTSS, an orthosis supporting the talonavicular joint will reduce symptoms of his pain. Cast correction. The most suitable cast correction for Paul would be a mid-orthosis style with a moderate orthotic force of 6. This is taking into consideration 3 important factors of body weight, type and level of activity, and comfort. Paul is wanting to increase his fitness levels, and this can be associated with an initial increased body weight. The heavier the individual, the greater orthotic force is required to avoid deformation of the orthosis material. An increase in body weight has also shown to be a risk factor for MTSS, according to a study by Rain King and others. Paul has also been running 20 kilometers per week, which many would suggest running generates a large force, meaning a greater orthosis force will be required. Lastly, the orthosis needs to provide comfort for Paul with an appropriate amount of force. Paul has a highly mobile foot, meaning that with too much orthotic force, he may feel the orthosis to provide too much pressure, leading to discomfort. Shell material. For Paul, the most appropriate shell material would be moderate material EVA. This is because EVA provides shock absorption, and as previously mentioned, shock absorption insoles can be an important preventative factor in reducing symptoms of MTSS, according to Craig. Also, the moderate density of the EVA orthosis still provides the support with its firm nature. Comparing EVA to a carbon fiber material, which is formed from carbon atoms and thus the material incredibly strong in tension, this material would not be suitable for Paul. The hard density provides limited shock absorption, which will not assist Paul in managing his MTSS. Cast modifications. An appropriate cast modification for Paul would be a lateral plantar grind. This is because a lateral plantar grind will allow for better fitting in his shoe, and the orthosis will follow the contour of the shoe shank. Therefore, this will provide further comfort for Paul when he is running.
In terms of actually prescribing an orthotic for a person with medial tibial stress syndrome, it's hard to evaluate the one orthotic that fits all. However, in saying that, I would recommend that Paul's orthotic has a heel stabilizer incorporated into it. Our main aim is to try and center the ground reaction force more medially, designed with a rear foot varus post or a medial wedge to control the excessive calcaneal eversion moment at the subtalar joint. A forefoot varus extension in order to shift the center of pressure more medially, which will reduce the magnitude of pronation moments at the subtalar joint axis. Depending on how medially deviated the subtalar joint axis is, this may result in a shorter lever arm lateral to the subtalar joint axis, reducing the magnitude of the pronation moments at the subtalar joint. Or there will be a massive compressive force due to there potentially being no lever arm. In both cases, center of pressure should be shifted medially, which is one of the aims of prescribing the orthotic. The forefoot varus wedge will also tend to increase force on the medial forefoot, specifically the first ray. This may be counterintuitive because implementing a forefoot varus will restrict the first MTPJ range of motion. This is why you may choose to add a first ray cutout to accommodate for the first MTPJ range of motion. Neoprene would be used as a top cover selection as it provides good shock attenuation, which is a necessity with patients with MTSS. Also, it is really good to provide a full-length cover because it will be able to distribute plantar pressures more evenly. However, there is a drawback with a neoprene top cover in the fact that it's not breathable, unlike some of the other materials. No further additions would be made to the orthotic as it's not needed. Adding more additions to the orthotic will make it too thick and not suitable for our client Paul. Here is our orthotic prescription.
A systematic review that was done in 2016 investigated the effectiveness of foot orthosis and shock-absorbing insoles in preventing injuries, such as medial tibial stress syndrome, Achilles tendinopathy, plantar fasciitis, and patellofemoral pain. This systematic review looked into 18 trials, 11 trials that had investigated foot orthosis, and 7 that investigated shock-absorbing insoles. Orthoses are commonly used to absorb shock and/or increase their plantar pressure surface area in a specific foot type. Paul suffers from MTSS, which is more related to a pronated foot type. He will require a midfoot orthosis which decreases the navicular drop and resupinates his foot to a more normal range. The systematic review shows that 4 out of the 11 trials that had foot orthosis, either customized and/or prefabricated, have proven to reduce stress fractures in the lower limb, and that this intervention was very effective in preventing tibial stress fractures. A randomized control trial performed in 1990 by Schwellnus, which compared standard military footwear with shock-absorbing flat insoles. The results of this trial showed that the shock-absorbing flat insoles group experienced a significantly lower incidence of overuse injury. However, overall, from the 7 trials that evaluated the shock-absorbing insoles for the prevention of injury, the overall result from those trials have indicated that shock-absorbing insoles were not very effective in preventing injury compared to the control groups. Therefore, according to this systematic review, a midfoot orthosis is the best option for Paul. The midfoot orthosis will provide support to Paul's midfoot, which will significantly decrease his MTSS pain, as well as assist his borderline pronated foot to a mildly pronated foot which falls into the normal range.
Non-orthotic interventions. Interventions to reduce stress and load on the injured tissues include gait retraining and taping. In terms of gait retraining, the results from a study performed by Carroll and Davis show that gait retraining can reduce peak impact applied to the lower limbs during gait. Results from the study include a reduction in peak positive tibial acceleration during stance by 50% and a reduced peak vertical forces and peak loading rates during heel contact by 30%. These successful outcomes of the retraining program were still preserved following a 1-month follow-up session. In terms of taping, taping is easily manipulated and beneficial in providing a degree of support, correction, and stabilization of muscles and joints. Taping can be used to apply forces and pressures that can reduce the development of further or potential pain and injuries. A study conducted by Gilbert and others achieved results that confirm that the use of kinesiotape reduces loading rates within sufferers of medial tibial stress syndrome. The study involved collecting data by having patients walk across a mat that recorded plantar pressures before, directly after, and after a day of fully continuously wearing the tape. The study overall successfully concluded that the tape achieved a decrease in medial loading rates within patients of medial tibial stress syndrome. Taping, therefore, would be a well-reasoned incorporation into Paul's management plan. Additions that can be put in place for Paul's treatment plan that will increase the tissue's capacity to tolerate load include the performance of daily stretches and strength exercises in order to reduce the extent of muscle fatigue and achieve more strength and stability. Muscles help neutralize forces acquired from impact by contracting in the opposite direction to the movement occurring within the bone. When muscles become overused and fatigued, a reduction in sensory feedback and shock absorbance occur, resulting in the increased effect of ground force reactions being poorly diffused, contributing impact to the tibia. Performing eccentric calf stretches can help increase triceps surae flexibility and build on dorsiflexion range of motion overall, reducing the load on the tibia. Stretching and strength exercises are great measures to increase tolerance of load and enhance endurance. Although, as Paul is already suffering from injury, we do not want to overwork or excessively stretch muscles and potentially cause any further pain or injury. References. Thank you for watching.